What are some of those digestive symptoms, that people should watch out for that you cannot ignore? And when is it time to come and talk to you?
A lot of GI symptoms can be very vague. If you have a family member who's been diagnosed with cancer at any age earlier than when you should have started screening, we simply reduce that from when that person was diagnosed, decrease that age by 10. For example, you were diagnosed at the age of 40. If you decrease that age by 10, it's 30. So all your first degree relatives, and by first degree relatives, we're referring to you, your brothers,
Yeah.
and your children, will start screening at the age of 30. These are patients that will start screening at the age of 13,
13?
13 years.
So that screening is informed by if a grandparent, if
Yes,
a
and
father.
we have criteria for diagnosis.
Dr. G. Real stories, real people, unpacking the struggles, reclaiming the narratives with Dr. G.
This conversation is not a medical advice, it's not a prescription. This is a conversation for educational purposes. A lot of people just see you in occasion and say, Doc, 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 Doc. A lot of us know you as Doc, Doc, Doc. I don't think there are so many people who know exactly what your specialty is. Can you clearly explain that to us? Even the word is so difficult to pronounce. Not many people will be able to get it right. Gastroenterologist. Am I getting it right?
That's correct. Gastroenterology and hepatology.
Please, Doc, clarify us. What does that even mean? What do you do? What are you focused on?
Yeah, you're right. That a lot of people have trouble pronouncing that word. A gastroenterologist, as the word itself, gastro means stomach, eat, and enterology refers to the intestines. So a gastroenterologist is a specialist under the bigger term of internal medicine. People who can do internal medicine and stop there and become a primary care physician or a hospitalist in the hospital. Or they can choose to subspecialize in different fields under internal medicine.
Okay.
And one of those fields is gastroenterology. Just like you have cardiology, nephrology, rheumatology.
Okay.
Gastroenterology is one of those. And as a gastroenterologist, my daily responsibilities are taking care of digestive diseases. And by digestive diseases, we're referring to any condition that can affect from the esophagus, or what we call the food pipe, the stomach, and your intestines. Attached to that system are some organs which also participate in digestion. And these are the pancreas, the liver, and also the gallbladder. So the liver, of course, somebody that specializes only on taking care of the liver is called a hepatologist.
Okay.
Yeah. So as a gastroenterologist, hepatology, I focus on the digestive system as I just described, and also on treating patients with liver conditions. Just so our audience can understand better, some of the conditions that typically I will deal with will include things like gastritis, ulcer disease in the stomach, people with diarrhea, people with abdominal pain, constipation, people seeing blood in their stool.
Wow.
And apart from those things, I talked about the gallbladder, people with gallstones, people with liver conditions known as hepatitis or inflammation, people that can also have pancreas problems such as pancreatitis. But it's also important to know that a bigger portion of my practice focuses on procedures, and we perform endoscopic procedures, so where they pass a camera through your mouth to look into your food pipe, your stomach, and the upper part of your intestines, as well as a colonoscopy, where I know people hate to talk about colonoscopy because it relates to poop, but it's a very important aspect of my practice.
Wow.
Where we have to go into your intestines and look all around for disease, which most often has not caused any symptoms. And so you can be sitting there at home thinking that you're perfectly healthy, whereas there are things going on in your body. And the colonoscopy, which I think we will talk more about, is one of those very important things that I do on a daily basis. So again, in summary, a gastroenterologist, hepatologist simply takes care of digestive problems, as I cited above, but also problems that affect the liver, the gallbladder as well as the pancreas.
Okay. Well, anything with the kidney?
Not specifically as a gastroenterologist. For sure, when one of the systems of the body is affected, you can wonder if other organs can be affected. But the kidney is specifically treated by a specialist, a subspecialty under internal medicine, by folks that we call nephrologists.
Yeah.
So most often than not, a lot of the patients I deal with, especially those with liver disease, known as the most common being liver cirrhosis, are at significant risk of kidney injury. So we often work with the kidney specialist or the nephrologist.
You know, as you were just explaining, if something is wrong with one aspect or one part of that internal, those internal organs that help with digestion, it could just have effect with other parts because we are just so interconnected inside.
That's correct.
Yeah, yeah. But that is really a good clarity even for me. I really did not get that. And now once people understand what you cover, my next question is very practical. You just mentioned that sometimes people sit at home and you think that you're okay. Maybe you just have a headache. Maybe you just feel stomach ache. But nothing too serious. So you don't care. You don't bother to go. Are there any signs and symptoms that should make you wake up? What are some of those digestive symptoms, you know, that people should watch out for that you cannot ignore? And when is it time to come and talk to you?
Yeah, that's a very important point, and I'm glad that at the end there you clarify that we're talking about the digestive system here. I'm not going because we start talking about signs and symptoms. We can spend the whole day here, and we will not finish this discussion. So a lot of GI symptoms can be very vague.
GI.
Gastroenterologist, gastrointestinal symptoms.
Okay.
That's correct. GI means gastrointestinal symptoms.
So we'll use that moving forward.
Yes. And yes, so the audience can understand better. There are so many, but what I often tell my patients are some red flags that you should not ignore. In medicine, we call those alarm symptoms. The first thing is that I tell my patients, if you start seeing blood in your stool, you got to wake up, call your doctor to find out what is going on. I'm not saying blood in stool means you have cancer, for example.
Yeah.
The most common causes of blood in the stool are benign, meaning they are not cancerous. They are not things that are going to kill you. But it is an alarm symptom that should wake you up in the middle of the night to go see your physician. The other alarm symptoms that I talk about, if you have trouble swallowing, remember we said the digestive system includes the food pipe. If you're eating food and feeling like it's getting stuck, it's not going down. Usually when we swallow food, it takes about 10 seconds to travel the food pipe into the stomach. And if you discover that, oh, the food is caught, and you have to somehow cough it up.
Yeah.
It's in medicine, we call that dysphagia. This simply means difficulty. Phage means swallowing.
Okay.
So dysphagia means difficulty with swallowing. You got to talk to your doctor. If you're having persistent abdominal pain.
So just hold it there, doc. Say I'm just eating, maybe the food is too dry, and maybe it goes into my esophagus, and is that alarming? Should I not just cough, drink water,
and you're right. But even in that, a lot of the times, it's not due to something bad.
Yeah.
Okay. But if you, and we're not, normally patients don't come when they feel something once.
Yeah.
If you were eating and talking, and then food went the wrong way, and then you cough, that's a different thing.
Okay.
But we're talking of somebody who was sitting and eating, and the food, as they swallow their food, they feel like, oh, that food is
it
caught.
didn't go? Yeah.
It's blocked here. Sometimes they have to do maneuvers, lean forward, stretch their necks to breathe and get it out, or drink water, or do a lot of things. And if that were to be occurring,
like 2 times in a day,
2 times, or even once a week,
time.
once 3 times a month, and if it becomes a recurrent issue, I will advise you to talk to your physician. Even if it occurred just once or twice, but you were concerned enough I would suggest that you talk to your doctor, allow him to make the decision, him or her, to make the decision
Yeah.
whether this is something that's worth looking further into, or it was just a one-time thing related to the fact that you were eating grains and dry food and talking, and some of it went the wrong way.
Thanks.
And even on that, if people that don't have saliva in their mouths, for example, they cannot form a good bolus. They can't moisten the food to allow it to form a good bolus for you to swallow. So if you come to me with problems swallowing, I will need to make sure that you have teeth. If you don't have teeth, you can't chew. So you'll have trouble forming a good bolus that can go down. That patients will report it as I have trouble swallowing.
Yeah.
It's not really a food pipe problem. It's more you don't have teeth. If you have, there's a condition we call Sjogren syndrome, which is an autoimmune disease, where the salivary glands can be damaged, and you're no longer able to produce saliva. You will have trouble forming a bolus, and that will make it difficult for you to initiate the swallow. So to move the food to the back of your throat and then get it into the airway.
Yeah.
That can also, you will come to me. So it's when you come to me, we will take a very good history and examine, starting by looking into your mouth. And if you already have a diagnosis of Sjogren, those people will have dry mouth. They would have already been complaining. Have dry mouth. Sometimes they don't have tears because most of those glands, just like the saliva, will also be damaged. That will help me say, no, this is really not a food pipe problem. The problem is that you're not able to form a bolus. So going back to the alarm symptoms, we talked about the blood in stool. We talked about the difficulty swallowing. We talked, if you have persistent abdominal pain or acute severe abdominal pain, you want to make sure you get evaluated. The other alarm symptom will be persistent nausea and vomiting. You can't keep food down. That could be associated with other symptoms, pain, anything, but that will also be something you don't want to sit at home with. Chronic diarrhea, that will require further investigations. The other thing is your doctor will typically may draw some blood tests, and one of the things we also look for is anemia. Anemia meaning your hemoglobin or your blood counts are very low because, as you know, iron, you eat food, it has iron, and it has to be absorbed. And if you have problems with your digestive system, you may not be absorbing iron. But also, if you have something like a tumor or cancer, you bleed slowly from that, and that will lead to anemia or low hemoglobin. And once we pick on that, I guarantee you're going to be getting some kind of gastrointestinal investigation, because that's typically one of the most common causes of iron deficiency anemia. One other very important symptom is unexplained weight loss, or what we call abnormal weight loss. And technically that's defined as a weight loss of about 5 to 10% within a period of about 6 months. If you lose that amount of weight when you were not trying, we're not talking of people taking the weight loss medications, or folks who have engaged in very intense physical activity to lose weight, or they've decided to go on fasting. If you did not make a decision to lose weight, and you find out that over a period of about 6 months, you've lost about 5 to 10% of your body weight, that's an alarm symptom. Others are non-specific, like changes in appetite or severe fatigue. Those are non-specific. But the things that I mentioned will be considered alarm symptoms for which further investigations are warranted. Now, before you move on from this, I want the audience to know that unfortunately, a lot of digestive problems do not show up with symptoms. Particularly, I'm looking at colon cancer. So for us GI physicians, while we diagnose based on symptoms and signs, our most of what we focus on is how can we prevent these things from happening. And one of my main job is colon cancer screening, which I'm sure we will talk about more in detail. And I want the audience to remember that signs or symptoms is your body speaking to you. Listen to your body. Act early. Because when you act early, we may catch whatever is going on at the stage
Yeah.
where you can be cured. If you wait and only come in late, most often than not, you may not be very happy with what I will be telling you.
Yeah.
So listen to your body. If you have doubts, please talk to somebody, talk to your physician, and they'll be able to guide you to the right direction.
Yeah. In fact, you just went to the next question directly, because I was going to ask you about the prevention. You know, when I was growing up, we used to say prevention is better than cure. Sometimes we are even singing it in songs as we carry our armboards and go to school. You know, prevention is better. And this thing was very common when malaria became a pandemic.
That's
you
right.
know, and we must drive mosquito away. You know, malaria is a very bad disease. But,
Yeah.
you know, for most African immigrants, and I'm focusing on African immigrants here, but maybe it's a disservice to other cultures and other people, because I've lived in other continents and I've seen how people don't really take prevention seriously. You know, some people pray about it. Some people say we'll use home remedy. Some people are shy to go to the hospital, you know. How important is it for us to not wait until we are falling down, until we cannot walk, before we come to the hospital?
Yeah, that's a very important point you raise right there. And it's not uncommon that immigrants often come to us when it is too late. I earlier mentioned that when you have any symptom, it is the way your body tries to communicate to you that something is wrong. And I would invite, irrespective whether you're an immigrant or not, that should speak to you. And even if you were one of those that usually doesn't visit with a physician, that should be the moment, that should be a wake-up call to go see your physician.
Yeah.
By the time you have symptoms, it typically means you've got disease at an advanced stage. Therefore, prevention, which is what I will argue is where medicine is moving to, is the best strategy. But if you cannot prevent, come in early when it's just beginning. If you wait for months, sometimes even weeks, you wait for months, you wait for a year before you finally come to see us, it may be too late. That could be your life simply over. So prevention is what I preach. And as I alluded to before, it's a majority of what I do, primarily focusing on colon cancer. And colon cancer, fortunately, is one of the conditions that we have ways to screen for. The word screening is completely different from diagnosis. If you come to see me with symptoms, I'm trying to diagnose what caused the symptoms. Screening means somebody who has no symptoms, but we decide to go look if there are problems. And why is that so? It is so because when disease begins, it often has no symptoms. But it's growing, it's brewing. And how will you then know that you have it if you have no symptoms? So there are a few of these conditions, amongst which is the colon cancer, which we know that from a certain age, people are likely to start having the precancerous lesions. Meaning the lesion begins to grow, but it's not yet cancer. It's a benign lesion. In the case of colon cancer, we look for something called polyps. And polyps are abnormal growths, like a small bump, that grows on the wall inside the stomach, inside the intestines lining, the large colon, or the large intestine.
Yeah.
And it can take about 10 years for it to grow and become a cancer. Therefore, during that 10-year interval, if you happen to undergo a screening procedure, because remember, during that time, you have no symptoms.
Yeah.
You have no symptoms.
10 years, yeah.
So if within that window, if we happen to do a test, a colonoscopy, for example, we will most likely find this polyp, take it out, and you will never develop cancer. At least from that polyp. I'm talking of colon cancer. It doesn't mean if they remove colon cancer, you won't have kidney cancer.
Yeah,
No.
or breast
But
cancer,
yes,
yeah.
But this is specifically when it comes to colon cancer. And colon cancer screening starts at the age of 45. Meaning every person, irrespective of gender or age, who falls within what we define as average risk, should start a colon cancer screening at the age of 45. There are some people that start early, but that's informed by their family risk or their personal history. And those specific cases, your doctor will be the one that tells you that, hey, because you have this and that, you may be at risk, at higher risk of colon cancer, and you may need to start early. For example, there is a condition we call familial adenomatosis polyposis syndrome, or which is called FAP. It just means familiar. So families have this genetic condition in which they develop adenoma. Adenomas are polyps. So familial adenomatous polyposis syndrome. And these are patients that will start screening at the age of 13.
13?
13 years.
So that screening is informed by if a grandparent, if
Yes,
a
and
father.
we have criteria for diagnosis, and there is a genetic test. Typically, these folks come from families where colon cancer, perhaps the first person died early, and then they went in, they did an autopsy, they found out they had a cancer, they did genetic testing, and it showed that there was a germline mutation or a genetic mutation in that family. Those patients will start colon cancer screening at the age of 13.
Doctor, I'm so scared.
And they'll get it every year for the rest of their lives. And those that have that genetic mutation, it's just a matter of time. Their entire colon will come out. And usually these patients, when you see one, the entire colon is filled with hundreds, if not thousands, of polyps. There is no space. You can't see the colon lining at all. It's covered like a carpet with polyps. And cancer will develop. It's not whether it will. It is just when it's going to happen. That's why they typically will just remove the colon once they start developing the polyps. The other example would be things like what we call Lynch syndrome, which is another genetic problem. Those people will start screening at the age of 20. So their risk is lower than that for patients, than those for patients with FAP. Yeah. So again, so based on that, and then if you have a family member who's been diagnosed with cancer at any age earlier than when you should have started screening, we simply reduce that from when that person was diagnosed, decrease that age by 10. For example, you were diagnosed at the age of 40. If you decrease that age by 10, it's 30. So all your first degree relatives, and by first degree relatives, we're referring to you, your brothers, and your children, will start screening at the age of 30. And there are other conditions too, some types of polyps that we call high-risk polyps, that if you have, it will also boil down to decreasing that age by 10 based on where you were diagnosed. But even if they decrease that by 10 and it falls above 40, you would typically start at 40. Again, that's not to make this discussion complex for the audience. Those are decisions that when normally you will sit with your provider who assesses your risk. I guess the take-home message here is that although we talk about signs and symptoms as a way your GI system is talking to you, there are many other conditions that your body is not talking to you about. And fortunately enough, for colon cancer, we know that's the case, and we have tools, amongst which is a colonoscopy. And if the other methods do exist. If you're scared of a colonoscopy, worried about it, we do stool-based tests, where you submit a stool sample and they're going to check for certain things within the stool secreted by polyps that if we find, then you will get a colonoscopy. There's also a type of CT scan called a virtual CT colonography that they can do, but usually that test is not done. It's not generally accepted unless a colonoscopy has not worked or you cannot have a colonoscopy. So different tools that you can use, but remember, when we are doing a screening test, typically means it is in another patient that has no symptoms.
Yeah.
But we know things can be growing. And in colon cancer, it can take 10 years for the polyp to grow. So going in during that time, and the age that has been set as when people should start, allows us to fall within that range of 10 years for patients who are at average risk, not at a high risk as we discussed in terms of those other conditions, to go in and catch these lesions at the time when they are benign, can be removed, and therefore protect you from developing future cancer.
This is my fear and question and challenge. First of all, we come from a place where this information is not even, it's not there. We don't have people coming to churches on a normal Sunday and telling people about colon cancer or colonoscopy. Maybe if they even come, we don't have the apparatus to go and check all these things and do the screening, I'm thinking of people have lost parents, people have lost uncles. They don't even care. They don't even know whether it's as a result of cancer. They don't even know if he had anything to do. And we just carry on with life. My parents, I have no clue. So do I have to wait till 45? Or can I do it before? I just need to know.
Yeah, and that's a good question. Sorry to hear about your parents, the loss of your parents. I know how painful that can be, having lost my dad as well.
Yeah.
I know every day we live with that memory.
Thank you.
I think one thing we can do is how we can maintain their legacy by bringing information to our people.
Yes.
Hopefully, if they happen to have passed away from one of those, we can help someone. So you're absolutely correct that most of us don't know our family history. Where I come from, if somebody died vomiting blood or perhaps with having bloody bowel movements, historically, that was considered a bad death.
Yeah, witchcraft even.
Witchcraft, yes.
They don't knock 'em.
Neighbors, people will be accused, where did he last eat? Whom was he with, and that he was probably poisoned. Or it's considered that you've died from some very bad disease. And those people were treated very differently. Sometimes people cannot even for example, if you have a distended belly, you can't go through the normal door. They have to create a passage through one of the corners of the house to get the body out, because it's bad deaths. So whereas it could have simply been they had colon cancer. Maybe they just had a stomach ulcer and they've just bled, vomited, and they are now treated. And it will create a lot of family feud where people may never talk to each other, claiming that you killed this person. So you're absolutely right, and it's a big problem in our community. So what I tell immigrants is that tell your physician you do not know your family history.
Instead of saying no.
Yes. And for me, when I talk to immigrants or see these patients, I would typically ask them to start screening at the age of 40, which is the age where people at higher risk, typically, if no other factor brings you earlier than 40, should start at 40. So I will suggest to immigrants, and that's certainly even within the guidelines, standard of care, that if you do not know your family history, you should start colon cancer screening at the age latest 40. But of course, if you're having symptoms, your body speaking to you, listen, go talk to your provider, and he will make a decision if you stand to benefit, or that do you need to have a colonoscopy. For sure, if you have any of the alarm symptoms that we had spoken about, I guarantee you, you're going to probably be getting a colonoscopy, irrespective of the age at which you're having those symptoms.
Wow. I want to have it. I want to have my screening maybe tomorrow. I'm not yet 40, doctor, but I'm frightened. I am frightened.
Yeah, you have to be. Yeah, you have to be. And hopefully, immigrants, folks in our community, where past history is often unknown, can talk to you. Just tell your physician, I don't know my past medical history. and they will offer you a colonoscopy by the age of 40.
And that brings me to the physician thing. In Cameroon, we know that a doctor is for 10 million people.
Yeah.
A doctor is for the whole division.
Yeah.
You know, we have one, maybe we don't even have a gastroenterologist in the whole of Southwest region or Northwest region. Or
I mean, you're right. And the situation of Cameroon is not too different from other African countries. But I must give credit to some of these countries that have made tremendous progress over the past few decades, even though the situation in Cameroon remains very abysmal.
Yeah.
But we do have gastroenterologists in Cameroon, and they have a fellowship program now where people are certainly being trained as gastroenterologists. I know a good number of them, primarily in the big urban areas. Of course, when resources are rare, it's very difficult to have them distributed to remote areas, and that's not unique to Cameroon. Even the United States, there are remote areas that no GI doctor wants to go to because the standard of living is just not what he can accept. But it's a difficult situation. Colon cancer screening is not recommended in Cameroon. It's not a standard of care. I mean, the national health policy does not
make it a recommendation
that people should be screened.
This is wrong.
This is, we talk about equity and access. Unfortunately, it may be wrong in a way, but if you look at the country and what we typically look at the epidemiological transition ladder, you'll find out that most people in Cameroon die from malaria or no access to drinking water, and they die from colon cancer. So if you have limited resources, where are you going to put those resources? Are you going to put them on perhaps the few, and perhaps people who've lived long enough to prevent colon cancer?
How many times do we check the cause of death? In Limbe, in Guti?
And it's certainly because colon cancer occurs at a much
lower rate,
older age, and the incidence is lower. We know that if you focus on preventing diseases related to basic needs, no food, dirty water with diarrhea, cholera, standing water, pots of water all over with mosquitoes breeding, causing malaria, typhoid fever. This is where developing countries are. And before you think about prevention, you must be able to even treat what exists. So if you cannot even handle the basic things, how can you begin to think about things that, in quote, were typically considered diseases of the rich?
In fact,
in the US, we're not talking about diarrhea as a big deal. We're not talking about food insecurity. We're not talking about basic life as a problem. They're talking about how much of this should I eat? In Cameroon, somebody is saying, can I have anything? So priorities are different.
You just nailed it.
The focus at this point, and in a way, which I do agree, should focus on what is the leading cause of death or mortality. Certainly, I hate to say this, if leadership or governance in Cameroon was anything that catered for its population or its people, we will not be where we are. We are there because we are stuck. And I think the Cameroonian people are not yet angry enough. They shall be angry enough or understand that it can be different. They will rise and say enough is enough. It's a disgrace.
Dr. G. Real stories, real people, unpacking the struggles, reclaiming the narratives with Dr. G.